Sidewalk Labs is this amazing opportunity to bring a bunch of technologists together with a bunch of urbanists to take advantage of the amazing things that technology has to offer with a deep understanding about what really makes cities tick.
Instead of saying a problem is just about technology or it's just about policy, in most cases the answer is it's both. We find the very best people in the world who can go and think about solving those types of problems.
I want to thank everybody for submitting so many great questions. We do have two moderators behind the scene here, just making sure we don't get duplicates and things like that. And we're going to try to get to as many as we can in the next half hour or so here. So I'm going to start with one of my own questions because it was upvoted the most times, not because it was mine. And I think that the big topic of the day, of course, is the Affordable Care Act. And so I wanted to ask our panelists here, how does the uncertain future of the Affordable Care Act kind of impact the momentum of the changes that we're seeing in healthcare in terms of thinking about this in a different way, in an outcomes-based way? What changes going forward do you see?
So happy to start with an easy question. Thank you.
Just solve it for us.
Yeah, solve healthcare. Okay. So the truth is, we were just chatting about this amongst the three of us because, of course, it's on everyone's mind, but it's really difficult to kind of answer this responsibly because I just think that the truth is we don't know. We don't know, if we're going to get a repeal and replace, if we're going to get a repeal and no replace. I think most kind of the wonkiest in the health policy community would say it's more likely we get a repeal and replace than a repeal and no replace, meaning we'll get some kind of plan. I think the key points, like high level, would just be for the kinds of things we're talking about, which is this move to embrace social services, social determinants of health. I don't think that's going anywhere. I don't think anything that the kind of Republican plans could put forward would really put like a big dent in that, in part because I think the things that a repeal and replace plan would be most likely to go after are things around insurance regulation, kind of what are the essential health benefits that are covered, what are the structure of the healthcare exchanges and the healthcare markets, can insurers sell across state lines, can you stay on your insurance until you're 26 or your parents' insurance? But what it seems that is probably not in danger is this like bigger thematic move that's been happening over the last probably 10 years maybe now, from fee-for-service financing to value-based financing. And so long as providers are getting paid for the value they provide, which is usually measured in terms of quality metrics or outcome metrics, meaning like, did you actually reduce that person's A1C level? So long as that is the general flavor of the financing, I think there remains every incentive in the world for healthcare providers and systems, and to some extent insurers, to really keep digging and trying to come up with innovative solutions about how to build in social services, social determinants of health. So that's not to say everything is fine. I harbor enormous concerns about the future of the ACA and what's going to happen to those insurance markets. I think we could have more uninsured people than we have right now in a few years. But I think that for the purposes of this conversation, I don't think we'll be back here in a year saying everything is now different around social determinants of health and the conversation about social need.
That makes sense. Do you, Manmeet or Aaron?
It's obviously premature from our vantage point to say too much. I mean, I think this idea of value-based care is something that resonates, and the move for value-based payment is something that resonates across audiences and left and right. And we have many years of experience under a Republican administration that's been very supportive of our work. And so from our vantage point, I think it's just make the best of it. And I think there's going to be a lot of potential statewide experimentation that's allowed through this. And so, we've had a great advocacy and policy efforts at the local level, at the county, at the state, and this, we're hopeful will open opportunities for states to have more flexibility over how they spend money, perhaps take into consideration more of the social determinants angles and give more flexibility there. So that's, as much as we've seen from our end or thought about it.
Yeah, I wouldn't add more to the shift to value-based and the uncertainty on the insurance markets.
Well, if we're talking about insurance, we have a question here from Shan. It says, I'm surprised insurance companies are not mentioned more. How do you think insurance companies affect the progress of changes in this field for better or worse?
I think they're often painted too negatively. I mean, the insurers have had the risk for the longest. I think the real problem is the lack of alignment of incentive for insurers and providers. And all the closed systems in the country, from Geisinger to Kaiser to Intermountain, will show, and entities that are really trying to build accountable care organizations are showing the power of collaboration and sharing the data that the insurance side has, and sharing the risks so that the payer and the provider are aligned. From our own experience, when I started City Health Works, I went to the payers, managed care organizations in New York, and the providers at the same time and said, what metrics would it take for us to convince you to pay for this service? And because we're operationally embedded in the provider sector, I didn't talk about insurers because we had very small amount of time. And also our strategy has been to first get the providers buy-in and then bring in the health plans as the payer.
Who's on first?
I mean, from our work, we've had insurance, managed care organizations that are incredibly friendly and supportive of our work, and others that we've struggled to engage. And I think, to paint it as a either or is problematic, in that, they're starting to realize the value of social determinants. They're starting to put their money, where their mouth is. They're starting to realize that there's a need for, they can only do so much, and that there's a need for local expertise. So whether it's, groups in Harlem or Camden, they don't have the on the ground community understanding or nuance to really do the work that's necessary to actually manage risk. And so we're seeing, an increasing amenability for partnerships, and it's really about sort of how do we create the policy lever changes that encourage the insurance companies that haven't been as forward thinking to get on board with that mentality.
I would just say, whoever holds the risk is the person who's going to be incentivized to think about upstream determinants of health, right? So that could be a provider who has alternative quality contracts or has entered into an ACO contract, or it could be a Medicaid managed care company who has gotten a pot of money and a set of lives that they're responsible for. So it's absolutely like wherever you see the capitation, that's where you're going to see the innovation around health and social service delivery. I think we've seen more innovation to date from the provider side because, in part, the providers see it more closely. They're able to do a lot of creative things with grant funding that doesn't really put them at risk. So a lot of the kind of models that I was talking about are initially grant funded, either by Robert Wood Johnson or other people like that. And they also have these kind of pots of money, community benefit spending, where they're starting to do some innovation. So I think the providers have been out in front experimenting for whatever reason, both because there's money available and maybe because they see the need in more real time. But in terms of the structure of the system, whoever holds the capitated payment is the one who's going to do the innovation. So whoever raised the question about why not talk more about insurers, exactly right. They're right there and having to fight through all this with us.
And just to add, in New York got an $8 billion Medicaid waiver to, essentially you can think of it as business development dollars for the provider sector to shift from their care models to move away from fee-for-service to value-based. And it was an explicit decision by the New York State Medicaid division that said, we're not giving it to the payers, it's going to the providers because they're the ones who see patients. And so in terms of redesigning care, it should go there, and then payers should be testing alongside to see what's working to be paying for long-term.
I have a question here. We have a question from Jen Nels here that says, and I think this is going to start with you, Lauren. Do correlations between social spending and health hold at the local level? You were talking obviously about the national level. If so, which areas of specifically local social spending are more effective?
The answer is I don't know for sure. I would presume, seeing as it holds at all the other levels, that it would hold at the local level, but I've never really run the regression to be absolutely positive and give you data or point you to a citation. That being said, I would take the opportunity just to say it's very difficult. This is just in the spirit of being transparent about my own research, and someone used the word correlation, so it's worth highlighting that these are correlations, right? We know that the ratio is correlated with these better health outcomes, and we have kind of pushed on the mental model of more spending in social services will likely beget you better health outcomes. However, there's a really fair critique of the work that says, why aren't we sure that the causal arrow runs the other way? I think in my heart of hearts, the causal arrow runs both ways, meaning countries or states or localities that put more money into social services will get better, healthier populations. And at the same time, if you have a healthier population, you have to spend less money on your medical care. They're consuming less healthcare services, and so your ratio is able to look more like it's prioritizing social services. So I think it runs both ways. We've commented on that in some of our work, but in case anyone was gonna raise their hand about, correlation isn't causation, I would put that on the table. I think it goes both ways. And that's part of what makes this such a wicked problem, right? Because once you start confiscating resources from social services for health services, you're likely to get a healthier population that then just continues to consume more health services. And so that's the kind of loop that we're stuck in, certainly in Massachusetts, and we've seen this over time, that social service spending has dwindled at the state level as health service spending has risen at the state level. And so trying to extract ourselves from that vicious cycle and take a pause and say, wait, how do we correct this imbalance is kind of where we're at right now.
Aaron, do you want to take that maybe through the perspective of what other data sets might you integrate and incorporate into your analyses to improve the types of care effectiveness you can deliver?
I mean, you saw it through, touched on through, pieces of the presentation, but, to get ahead of the stream, I think this idea of, bringing education data in and understanding social networks and the multi-generational, nature of these issues, we see for the individuals that we're engaging, a slightly younger generation that's touching the systems in a slightly different way, or maybe their kids are, starting to experience poor outcomes in schools. And so really, as far as, what are the priorities, I mean, these should look different in each of the, each community based on, who are the assets, in the community, who are the leaders that want to take this kind of integrated cross-sector approach, what are the local needs that we need to take into consideration. So, we have a tremendous housing, vulnerability issue in Camden, and so that's the sort of direction of, we need to get access to housing data, or we have a city that's perennially ranked among the most dangerous, and so, and a police chief that is, being hailed among one of the, the visionaries for community policing. And so you start with where you have, a foothold in it. You build a sort of proof of concept. There's lots of low-hanging fruit in this space, and then try and branch out and bring in new partners. So I think the recipe looks a little bit different in each community, but it's really sort of starting to build those relationships that take time and a local rooted understanding.
Yeah, I could add, I mean, one thing that we're discovering is because our clients tell us a lot of things that they're uncomfortable saying either to a provider or uncomfortable getting a service for before a coach helps them make them feel less stigmatized about it or less shame about it. We capture a lot of real-time data on their social lives or their interpersonal lives that are either not captured elsewhere or come up much later. And so a lot of data sets, especially government ones, are very old. And so we're working with the Urban Institute on thinking through how to leverage that and how to use it as a policy tool in neighborhoods to help with building upon the work Camden's doing and saying, here's the scorecard for this community of how many times this issue came up, or how many times, what was the frequency and what was our success with social issues to help inform which areas it's more worth investing in versus others, given the complexity and breadth of social issues one could address.
And just one more thing to add. I mean, a lot of our work is focused on sort of showing the downstream implications of underinvestment in social services. So that's why we have the criminal justice, or we have the hospital data to really get ahead of the curve. Starting to build inroads with the actual social service providers, and to be able to link that data in and be able to tell a really nuanced story of, okay, if I make these referrals, and this is really what's at the root of the accountable health community's efforts, is being able to map people through the system and understand what are the right places that we need to be steering people, and what are the best services that are out there in the community for the right people. So I think from our vantage point, start with what are the right cost levers that help make that argument to people, but then it really, criminal justice data criminalizes populations, and there's inherent biases and limitations there. So it's really about tapping and getting to know the patient's story, the social service landscape, as well as all those other points.
I'm going to draw on the patient story point, but this is a question for Manmeet from Nigel. It says, how has the relationship between physician and patient changed due to the introduction of health coaches?
I'm glad you asked that question. That's a very rewarding and huge area of impact for both the clinicians and the coaches and the patients. I would say what's so across the board, it's a data point for 1 in 2 patients. We inform the clinical team. It depends on the issue, is whether it goes to the social worker or whether it goes to the doctor, about something they didn't know. And I'll just give you 2 examples of those types of situations, and you'll get a sense of just how dramatic of effect it has on clinical decision making and trust and relationship. One is a patient who was had a prescription that was a 30 milligram a day, 3-time-a-day pill that got switched by the health plan to a 1 pill a day, 90 milligram dose. And they dutifully went and got the new prescription, but started taking the 90-day pill 3 times a day and thought they were doing the right thing. And it was after some time that our health coach realized what the person was doing and how it was connecting to a symptom that was flaring up. And this doctor is one who that person's seen for years, who speaks Spanish, who's an amazing provider, who just wouldn't have been able to pick up on that. And just to give a scale of the types of issues we escalate, 40% of those 1 and 2 are medication related, either fears, myths, barriers, cost, and a lot of it just not understanding fully how to manage. And it's tough when you've got 7, 8, 9, 10 medications. Our average number of medications is 8. And so but another big area is just language. So a lot of our clients, 40%, don't speak English well. And so patients hate the translator, and they hate when the doctor says, I speak Spanish, but they really don't speak it very well, because the health is so deeply personal, and that's one of the biggest complaints we get when that happens. And so there are a multitude of ways, both in terms of emergencies that we detect, but also just insights that are more about that person, that uncover things that they can talk about or feel less, of a barrier. Yeah.
I might just offer a more general point, which is often I talk to groups, particularly when I'm with physicians. I get a bad rap because I'm up there showing them diagrams about, nutrition's important, and housing, and, transportation. And often they feel like, oh, get her out of here. She's just like muddying the waters and trying to distract me from what I'm really trained to do. But the bottom line for me is that it's only when the system can integrate these things that the provider can actually be freed up to going back to delivering clinical care. And so that's the really big insight. Thank you. So when I was out in Portland, Oregon, we wrote this up for the book, but we were doing a case study, and this physician told us this brilliant story about she was in an integrated kind of a situation where a local community center was doing a lot of the nutrition and the cooking classes and the case management. And she said to me, we were asking her about her experience, and she said, Lauren, I absolutely love it. I trained to be an internal medicine physician. I geek out on this stuff. This is what I love. This is what I know I'm good at. And for 15 years, I've been faking it as a social worker and as a nutritionist and as a care coordinator, none of which I'm trained to do. And this finally let me go back to kind of my roots and to my passion and to what I love. And so that's what I'm trying to achieve. And so yes, it looks complicated when I put a hub and spoke model up and I say, look, we need to somehow build these pieces together. When I say that, I mean it at the system level, right? There need to be contracts. There needs to be a work through for HIPAA. There needs to be EMR interoperability. But what I'm trying to do is really allow each of those professionals in the system to go back to specializing and doing what they do best.
I think that there's a question here, I think, that draws on that very well. And we're talking about kind of thinking about this type of care in very specific ways. I'm trained as a physician in a specialty. Get out of my way so that I can do that specialty. This person is asking it with a number of upvotes, but anonymously asking, how do we integrate social services into healthcare and society when socialized medicine is such a taboo term in America? So basically, a similar question in terms of how do you get over the initial biases toward this whole concept of integration of these two areas, especially in a place like the U.S.?
Yeah, I mean, I think people who work in these sectors who are, I'll just say those doctors who work in these communities are the heroes of the story. They are the ones who just want to do their job more effectively, but have to play so many roles. And not just the doctors, the social workers, the case managers, anyone sitting in that clinic, they are these heroes because they're sticking with that job for as long as they do until they burn out and they leave, or they leave the profession, which happens a lot. And it is, it's about the how. It's not about should we do this or not. Is there resistance? There's such a consensus increasingly, but amongst medical providers, social service providers, that we need to communicate. But it's about the how. And that's complicated for a lot of reasons, and there are such exciting efforts that are starting to bridge that gap.
Yeah, I mean, I think from our vantage point, this has to be a grassroots level, ground up, ask the community what are the things that are meaningful to them. And if it's, building a new floor for a hospital, I don't think that will likely come up. I think that there's a lot of other needs that are particularly acute when you see blighted streets, that, like vacant properties, lack of access to good food options. So I think really making it something that's community-led so that their voice is represented, that's the only way, this kind of top-down approach of, we need to encompass the social determinants in healthcare, that we need the policy levers that enable the communities to be able to make these kinds of decisions, but making it ground up is the way that I think it will actually play out.
Yeah, and I think the simplest answer to like how do you work through all the fears of socialized medicine is you say it saves money, which it does. And so I think we can bear that out with the research. That's not going to overcome entirely the stigma around providing things, particularly for poor people and particularly for poor people who often are non-white. There's always going to be those kind of hurdles. I shouldn't say always. For now, I think there still will be hurdles. But I think the cost argument gets us a lot of the way down the road when people are really waking up to the fact that like 18% of GDP and we are 28th in maternal mortality. Like that has finally set in for folks. And so I would lead with the cost argument.
We have a question down here that I think I'm partial to asking as we think about the urbanist technologist divide and data more broadly. It's as you integrate health data with other data sets and social service data sets in particular for population prediction, how do you address privacy and ethical concerns, or are there misconceptions about those concerns?
I mean, there's certainly a lot of misconceptions about that and HIPAA being used as a barrier for data sharing, but then there are also very real privacy and ethical concerns to this. And so I think, again, going back to my sort of community-based approach, the coalition is very much, it's a neutral organization. We think of ourselves kind of like a Switzerland sitting amongst a variety of different players. And so, we have authenticity in that we've been around. We're not coming at this as outsiders trying to solve a problem. And so I think that, building the trust of the community is the sort of foundation that you need to start from. And then, the approach of let's bring the data together to show that, whether we want the data to be, in everyone's hands for case management purposes and the ability to make decisions, we know that our populations are intertwined and that, how can we fundamentally do our jobs if we're not collaborating and being able to share information about our patients. And so starting with that sort of aggregate level analysis is a really sort of powerful platform, and then pushing that into what are the real implications of pushing that information into different audiences. And all of the concerns can be worked out. I mean, there's a lot, we've had lots of relationship building with the legal counsel across hospitals and with various social service partners. And there certainly are real barriers that exist, but with the right thoughtfulness and with the right relationships, those things can be overcome. And it really starts with coming at it from the right angle of an authentic community-led effort.
Yeah, I would add also it's a big area. It's one, understanding the sensitivities and being mindful about who should see what information, but then making it easy as possible to communicate. So interoperability is a buzzword, a big need. It's complicated because you need to be designing and working within these systems to figure out what are those constraints from a legal perspective, from care delivery perspective to make it work. But I think there's huge need and opportunity from a tech perspective to help triage what goes to who and at what frequency and where it's received.
I think those concerns are usually a smokescreen for I don't want to work very hard to integrate care.
So smokescreen can't be one of your answers here, but this is from a local community member. She writes, or it's anonymous, so he or she, I'm a local community-based social services nonprofit. What top 3 tools do you have for me to improve my community's health outcomes?
Well, look at the care plan, ability to see the care plan that the other many people who are touching this patient are seeing. And I see Warrior nodding her head in the back because we are 2 years into the DISRA program in New York, the $8 billion Medicaid program. We're part of Mount Sinai's program, which has $400 million of it, and most of it's going into IT. And the question I've said for the last 2 years in meetings is the number one success we can do out of this $400 million is for Settlement Health, the home care agencies, the City Health Works, the domestic violence agency, for us to know what are the goals for this patient and who else is serving them.
Real quickly, we've been working on expanding our model, with lots of other communities across the country and building out a curriculum. So as far as just a concrete, set of tools, we have a lot of things around addiction, around engaging complex patients. What is our approach to care planning? That's all up on our website, complex.care, and I encourage you to look it out, check it out.
I'm still not really
You're gonna
clear
pass.
on the question.
Well, then I'm going to start with you on this one because I think you will have great insight. It's from Scott. It says, do patients believe that social services are as valuable to them as health services, or is the average patient biased in favor of health services?
That's a great question. I'm tempted to answer both ways, so I'll give you both answers and then we can think together about which one's better. On one hand, I think we have a tremendous cultural bias towards healthcare and medicine. There's enormous kind of social prestige in the doctor and in the white coat and in seeing a physician. And anyone who's tried to replace any kind of physician care with non-physician care will tell you it's very difficult. Being told to eat better by a social worker carries a different weight than it does when you're told by the doctor in the white coat who you address by Dr. Henderson, et cetera. And so I think all of the data also bears out that we have a virtually insatiable demand for healthcare. No matter how many times we try and bend that curve, people continue to still seemingly want more and more care, even when it's not very good, it's very costly, and it's not very convenient. On the other hand, social services often have a bad rap as being run poorly, they're mismanaged, they're small mom and pop nonprofits, and they don't have the same kind of gravitas. So on one hand, I think if we're thinking about people's mental images of the brick and mortar establishments and what kind of care they get in them, I think there is a tremendous bias towards going to a hospital, going to a clinic, seeing a doctor. That being said, if you ask people in their heart of hearts, what makes you healthy? Everyone knows the answer, and it's how much exercise do I get? Do I smoke or not? Do I have solid social relationships? How stressed am I? It's like the stuff that's on the back of a cereal box that you read when you're 5. And sometimes I can't believe that I'm getting a PhD to tell people the same information they read on the back of a cereal box when they were 5. So I think people know in their heart of hearts that the social determinants are the mainstays of what makes them healthy or sick. And yet, when it comes down to where do I want to go and who do I trust to deliver me a high quality service, we still just seem to have this knee-jerk reaction that you go to the hospital, you find the doctor.
Yeah, I think it's a good question. I think you'd get very different answers from our coaches and our clients. There is a mix, quite a gradient. I mean, there depends on who you're talking to and how sick they are, or what they're dealing with right now. Whether it's and not just sick, but how much in crisis they are with some dimension of their life. I think that as part of my commentary here, and something I want to do some more data-driven advocacy around, is reform in the social sector, because so much of the funding is government funding, and it's fee-for-service essentially. It's you get paid for touch points of seeing people, and a lot of foundations also operate this way. There isn't a mindset of what did you do in that social service that's actually resulting in what outcome. And right now we've got a good example in New York, the Medicaid Health Home Program, which was this massive care management investment where, today I could be earning, and I've chosen not to so far in our service, payments for just seeing patients. And it just rewards volume, not any outcomes, and there hasn't been any evaluation or real clarification of even what outcomes to look at. And so I think this emphasis, I wanted to make this point earlier, I forgot, so I'm glad this question came up. The emphasis on just spending on social sector, I would push back on and say, how much money, and I'd love for someone in the audience who's interested in doing this with me, how many dollars are going into Harlem, just Harlem, every year from government, philanthropic, private investments on social issues, and why is it so hard to have, to uplift this community? And I think in part it's very top down. So much of this money is spent in the social sector in a sense of you're a victim and I'm going to serve you. versus you have innate capabilities and strengths, you're going through some crisis, what is it that you need? And just an example of so many ones that make us knock our heads on the wall are a patient who was going to the emergency room because she was having falls, and because she had 5 people move into her apartment and is now on a broken sofa. And there was a provision with her health plan to pay for it, to have a new bed, and it took us 1 year. And imagine if she didn't have a coach who was coming back and saying, let me check, and actually call them and say, so our coaches will tell you, you get services if you know people. In NYCHA and in housing, we get people the mold assessment or things coming out because we know, they see us as knowing somebody. So I'm not as optimistic on just putting money into social sector because it needs massive reform and accountability by people in the community. And part of what we want to do is use our data around what referrals we're making actually result in what, and what hurdles do we need to go to help them actually get that service. It's not just the social sector, it's also someone's sense of confidence, getting over the stigma and shame of saying, I need help. And I know this deeply personally from my own life and family. So that's huge. And that's where I think this bridge of someone who's a personal relationship who can both navigate the system but also help people feel less of that fear or internal barrier.
You want to speak?
I mean,
okay, we're running up against time, so I'm going to ask one last question that just came in here because it's perfectly aligned with the theme of the evening, and is what would each of you like to see in terms of technological innovation in how can it help address the social determinants of health and improve health outcomes? Maybe one or two sentences each, and we can wrap it up.
Sure. So I think some kind of technological solution to, as Manmeet was saying, that can enhance the capacity of social services. If you come to a place like Camden and you see the, technological constraints, and we talk about lack of access to electronic medical records on the clinical side, but when you go into social services that are paper-based and aren't able to be thinking about how do we share information, that kind of stuff takes engagement. It takes tools that are simple. So I think something that is, simple to deploy, given the constraints that we have in many places. I mean, you can go to an office that might have very technologically savvy people, but come to Camden and you'll see that we need a lot of help to build this up from the ground and take into consideration the constraints that we have.
This is a very specific pipe dream of mine, but I'll pitch it to you since I figure there are people here who could do it. There are often providers in my hometown, Boston, who will have a client come in or a patient come in who they know is homeless. They see them, they bandage them up, they do the medical piece, and then they want to refer them to a shelter. In many cases, they just pick their favorite shelter, or they pick the shelter that they know best, they have a relationship at, and they send the person there. They say, go to Pine Street Inn. In many cases, Pine Street Inn doesn't have any beds. So imagine a way for the doctors to have some kind of dashboard that told them there are 3 beds available at this shelter, none at this shelter, 7 at this shelter, and be able to just see that kind of capacity availability in the social service sector. You could think about it as food banks, homeless shelters, pick your social service, but having a dashboard that shows the availability so that the referral can be made with real intent would be my pipe dream.
Yeah, I would reiterate her vision and highlight PCCI, the Parkland Innovation effort in Texas, which has been a real awesome pioneer around creating a software that CBOs can be using, linking it to the hospital, and actually giving a payment to community organizations for doing a service that's having an effect on readmissions. So, yeah.
I think, so let's end on this note of a theme I kept hearing over and over again, which was technology as kind of the enabler to let patients have more of a voice and to help coaches and providers in a community do their job more efficiently. Instead of technology up at the forefront, technology kind of in the background. I mean, Manmeet was talking about this when she compares technology to the plumbing. It's something that you actually shouldn't see or think about at all if you're doing it right in this context. And then Lauren earlier had talked about the findings that case management with a personal touch was much more effective than case management without a personal component. And I think as we sit here and look at bridging this gap between technology and care, it's important to understand that sometimes the best technology gets out of the way. So let me ask you to thank our speakers and our participants one more time. Manmeet Kaur, Aaron Truchil, and Lauren Taylor.